Okay, everybody, recording has started and we will be opening the webinar to all the attendees at this time.
Good afternoon, everyone. Welcome to the Colorectal Cancer Town Hall today. I'm Dr. Michelle Halyard. I'm a radiation oncologist at Mayo Clinic here in Arizona and also Dean of the Mayo Clinic Alex School of Medicine. I'm also a member of the Phoenix chapter of the LINCS Health and Human Services Committee. Today's town hall is a collaboration between the Phoenix chapter of the LINCS Incorporated and Mayo Clinic. It's part of a larger effort that came about as a result of a collaboration between the American Cancer Society and the National LINCS organization to address health disparities within the Black community. Today, you'll learn important information about colorectal cancer that we urge you to share with others who can't join us today. I'd like to turn it over to our moderator, Dr. Sharon Thompson. Dr. Thompson is a leader within the Black community here in Phoenix. She's a physician and the managing director of Central Phoenix Obstetrics and Gynecology. She's also an assistant professor at the University of Arizona College of Medicine, and importantly, co-chair of the Phoenix chapter of the LINCS Health and Human Services Committee. Dr. Thompson, I'll turn it over to you.
Good afternoon, everyone, and welcome. We are so thrilled to have you join us for these next 60 minutes. We hope that in this time, we will give you some information that will help you learn more about this so important topic and also feel more empowered to take charge of your health. Just a little tidbit about what we're talking about today. We're talking about colorectal cancer screening, and colorectal cancer is actually the third leading cause of cancer death in this country, excluding skin cancers. Each year in the US, there are over 100,000, just over 104,000 new cases of colon cancer every year, and just about 45,000 cases of rectal cancer. So this is a common disease and it's preventable. So we definitely want you to pay attention to the information today because it can go a long way to keeping you healthy and maybe helping family members as well. Today, we have an expert in the field who's going to share her knowledge with us. She's going to lead us through the ins and outs of what colon cancer is and also ways to prevent and to screen for it. It is my privilege to introduce Dr. Natalie Sansoni. Dr. Sansoni has a long and extensive CV. I'm going to read from some of it for you today. It is not going to be comprehensive, but I'll hit the highlights. Dr. Sansoni received a bachelor's degree in chemistry from Harvard University. She went on to receive her MD from MCP Hanneman, that's now called Drexel School of Medicine in Philadelphia, Pennsylvania. And she completed her internal medicine residency at New York Hospital in Queens. As a board-certified gastroenterologist, Dr. Sansoni ran her own practice in Connecticut for many years, and she subsequently moved here, where we have the joy of having her in our community here in Phoenix. And she works for the Veterans Administration here in Phoenix. Dr. Sansoni strongly believes in education, and that's how we were able to snag her today. While in Connecticut, she mentored school-age students whose parents were incarcerated, and she did that in conjunction with the Judy Dworkin Performance Project. And she was on the board of the Urban League of the Greater Hartford area. Here in Phoenix, Dr. Sansoni remains committed to education and community service. She is vice president of the Phoenix chapter of Jack and Jill of America, and she serves as chair of the annual Living History program. And I think they have a project coming up next month. She's also an active member of the LINCS Incorporated. And she helped the LINCS Incorporated to sponsor their very first tennis tournament because she is indeed an avid tennis player, an avid runner, and she's very interested in cooking. I can attest to that myself. I've had the pleasure. And today, Dr. Sansoni will bring us a wonderful presentation on colorectal cancer. Dr. Sansoni.
Dr. Sansoni, would you like to unmute yourself?
I was saying, good afternoon, Dr. Thompson, and thank you for the generous introduction. Thank you, Dr. Hilliard, for that very warm welcome. And thank you all for joining us this afternoon. Thank you to the Phoenix chapter of the LINCS, the Coalition of Blacks Against Cancer, the Mayo Clinic, for continuing your work in our community to promote awareness on these very important health concerns. As we will see with some of the data that I will present, the work being done towards colon cancer prevention and awareness has been instrumental in leading people to take more measures to get screened. The effort has led to prevention and early detection and has directly affected mortality. The current COVID climate is posing some challenges when it comes to maintaining the gain that we have achieved through education. This is why, more than ever, the work that the LINCS, CBBC, and Mayo are doing for awareness is so important. Early epidemiological studies published in the Journal of Gastrointestinal Cancer have helped to tease out some of what's happening globally. So let's take a look. Since we have an audience of people from diverse backgrounds, it's important that I start with some basic understanding of colorectal cancer and why it is important. Therefore, I will start with an overview of colorectal cancer. Thereafter, I will introduce some of the latest guidelines in regards to screening recommendations. I will show some data on the impact COVID has had on screening, diagnosis, and treatment, and then leave you with some practical applications and recommendations. One of the lessons that I've learned from living in the COVID environment is that as a health professional, I'm seeing more people who are interested in learning about the why, to make sense of the recommendations and guidelines that are out there prior to moving in the direction of making real life applications. Let's start with, what is a polyp? Why are they important to this discussion? Colon polyps are growths that develop in the lining of the colon and occurs when genetic mutations occur in normal tissue, causing clumps of cells to grow abnormally. Pictured on the left is your colon. When a colonoscopy is done to view the colon, the endoscopist is looking for polyps like the one pictured on the right. Colon polyps are important because some of them can grow or proliferate and become colon cancer and potentially spread to distant or organs outside of the colon. By removing colon polyps, we are preventing colorectal cancer from occurring. We use a staging system to determine how advanced colon cancer is when a polyp transforms into colon cancer. If it is found in the innermost lining of the colon, it is stage 0. When the cancer has spread beyond the inner layer but remains in the colon, it is stage 1. Stage 2 is when the cancer has grown outside the colon but has not spread to the lymph nodes. Stage 3 occurs when the cancer has spread to the lymph nodes, and stage 4 occurs when the cancer has spread to other organs of the body, most commonly as pictured here, the liver. The natural history of a colorectal cancer is that you either acquire or you are born with a genetic mutation that caused tissue growth abnormally in the colon. Several mutations occur during the process to lead to normal tissue to grow abnormally, developing a polyp and then transforming into cancer that can spread to distant organs. Few people are born with these mutations, but more people acquire these mutations during their lifetime. When you're born with these mutations, such as APC, MSH2, and MLH1, called hereditary syndromes, these mutations inactivate at some point and allow the colon and rectal cells to grow out of control. When we take a look at closer at this figure, we see that there are key periods during this process where having a colonoscopy to remove the growth can prevent colorectal cancer from occurring. Furthermore, we do not typically see signs from polyps and early cancers because more overt symptoms tend to develop later in the process. So what are the signs and symptoms of colorectal cancer? The signs and symptoms of colorectal cancer includes a change in your bowel habits that can present as diarrhea, constipation, or narrowing of the stool that lasts for more than a few days, a feeling that you need to have a bowel movement that is not relieved by having one, rectal bleeding with bright red blood per rectum, or blood in the stool that will make your stool look dark brown or black, crampy abdominal pain, weakness and fatigue, losing weight without trying. These are all symptoms that can be signs of colorectal cancer. But these symptoms are not reliable because they can present late in the course of the disease, and they're not specific to colorectal cancer. Many other diseases can present with these symptoms, so you should definitely consult your doctor if you're having any of these symptoms, but the guidelines and recommendations do not rely on these symptoms. They rely on age. So do not wait for symptoms to occur. Determine your risks based on your medical history and follow the guidelines based on that. Colorectal cancer is the third most common cancer. It's the third most prevalent cancer in the world and second deadliest cancer in the world. Your lifetime risk is at least 1 in 23 for men in the US and 1 in 25 for women in the US, but if it can be higher if you're not average risk. The American Cancer Society estimates that in 2021, there are about 150 new cases of colorectal cancer in the US alone. Let's look at the incidence and mortality of colorectal cancer in the US since the 1930s. This graph shows that consistently there's a higher incidence of colorectal cancer in men than in women, and the trend tends to be the same over time. The rates decreased from 1975 through the mid-1980s, but decreased thereafter. Prior to 2000, the incidence are thought to have decreased due to change in patterns of risk factors and increase in colorectal screening. The more accelerated decline is thought to have occurred as a result of widespread utilization of colonoscopy as a screening tool. The incidence have decelerated between 2012 and 2016, perhaps due to changes in risk factor exposures, potentially reflecting more African Americans getting less exercise and changes in diet and weight patterns. African Americans have the highest death rate and the shortest survival of any racial ethnic group for most cancers. This is true for colorectal cancer. Since the early 2000s, the death rates have declined by 1.8% per year in Hispanics and by 2.8% per year for Blacks, and in whites slowed from 2.5% per year from 2005 to 2012 to 1.6% from 2012 to 2017. As a result, the Black-white gap has slowly began to narrow. So the risk factors for colorectal cancer can be grouped as modifiable, which means changeable, or non-modifiable. Modifiable risk factors include being overweight with a body mass index of 30 or greater, having a lack of physical activity, having certain diets that are high in red meats, processed meats, cooking meats at very high temperatures, low blood levels of vitamin D, smoking or consuming more than 3 alcoholic beverages daily. Some of the non-modifiable risk factors include being 50 years or greater in age, having a personal or family history of colorectal polyps, cancers, or inflammatory bowel disease, having an inherited syndrome or type 2 diabetes. The information on the guidelines reflect recommendations for individuals determined to be average risk. You are average risk for colorectal cancer if you do not have a personal history of colorectal cancer or certain types of polyps, family history of colorectal cancer, a confirmed or suspected hereditary colorectal cancer syndrome such as familial adenomatous polyposis or Lynch syndrome, or hereditary non-polyposis, colon cancer, or HNPCC more commonly. A personal history of inflammatory bowel disease, which includes ulcerative colitis or Crohn's disease, or a personal history of abdominal or pelvic radiation for a previous cancer. Here are the organizations who have published guidelines for colorectal cancer screening. We're going to focus on the recommendations from the American Cancer Society, who last published recommendations in 2020, and the United States Multi-Society Task Force on Colorectal Cancer. It's important to know that in 2009, the American Cancer Society recommended that we first lower the age from 50 to 45 in African Americans in 2009. The American Cancer Society, they expanded that in 2018 to all average risk individuals, regardless of race and ethnicity, as did the US Preventative Service Task Force in 2020. And the American College of Gastroenterology followed suit last year in 2021. The adjustment was made in response to data showing that the colorectal cancer rate is increasing in people younger than 50, whereas the rates declined in older adults. There's full agreement that colorectal cancer screening is recommended for individuals between the ages of 50 and 75. Beyond the age of 75, recommendations lead towards continuing screening in selective people. Most organizations recognize that screening beyond the age of 85 is not recommended. Here's a slide showing what, helping to understand the previous recommendations that were made in regards to age-specific recommendations for having your colorectal cancer screening. And as you can see by this slide, the cancer incident rates increases with age. So currently there are three, we're gonna move along into the different screening methods that are out there for colorectal cancer screening. And I'm gonna start with the stool studies that are out there, and there are currently 3 types that are approved by the FDA. And the first one is the fecal guaiac occult blood And that is used, FOBT as you see here, and it uses a chemical to detect heme, a component of the blood protein hemoglobin, because it also detects heme in some foods, such as red meat. You are asked to avoid certain foods before having this test. The fecal immunochemical-based study, or more commonly the FIT, uses antibodies to detect hemoglobin protein specifically. Go back. The stool DNA detects hemoglobin along with certain DNA markers. And the DNA comes from cells in the lining of the colon and rectum that are shell and collected in stool as it passes through the large intestine and the rectum. Okay. So we'll jump along to the CT colonography, which is also called a virtual colonoscopy. And it uses X-ray equipment, a CT scanner, to produce a series of pictures of the colon and the rectum from outside the body. And then a computer then assembles these pictures into detailed images that can show polyps and other abnormalities. As with the standard colonoscopy, you will need a thorough cleansing of the colon before undergoing this test. If polyps or any abnormalities are found in the colon, then a colonoscopy must be performed. So there are two methods recommended that directly visualize the colon. Both methods can not only directly inspect, but you can also do definitive treatment while you're in the colon. And specifically, these are called the sigmoidoscopy and the colonoscopy, which we're all familiar with. The sigmoidoscopy only examines the left side of the colon. It traverses the rectal sigmoid and into the descending colon. It is recommended, if you use this method, that you combine it with one of the stool tests, which is done usually annually, and do this at a 5-year interval. The colonoscopy, however, with the sigmoidoscopy, you can get away with doing preparation that is more limited to the lower part of the colon with 2 enemas. With a colonoscopy, you will need to do a full bowel prep. And that usually includes fasting or just having clear liquids the day before and taking an extensive prep to thoroughly clean out the colon. What these 2 procedures are able to do is to give you more definitive treatments. So the Health Resources and Services Administration released this 2020 Uniform Data System data for the National Health Center Program awardees. And they report an overall colorectal cancer rate of screening rate of 40.1% in 2020. This is a decrease from the 2019 rate of 45.6% and reflective of the challenges that health centers face and continue to face due to the COVID pandemic. The impact of COVID-19 pandemic on colorectal cancer screening has led to changes in where we're seeing regionally, and that is usually dependent on the intensity of the outbreak and the degree of restrictions that your different municipalities have applied. It's affected treatment and has significantly decreased certain treatments for colorectal cancer, including delivery of surgery, chemotherapy, and long-term radiation therapy. We're seeing an increase, however, in emergency surgeries to address issues and short-term radiotherapy. Let's look at the information in terms of a bigger picture concept. This graph summarizes the life expectancy at birth in the United States. In 2020, the life expectancy at birth was 77.3 years, declining by 1.5 years from 78.8 in 2019. The life expectancy at birth for males was 74.5 years in 2020, representing a decline of 1.8 years from 76.3 years in 2019. For females, the life expectancy declined to 80.2, decreasing 1.2 years from 81.4 in 2019. This is the lowest that we've seen since 2003. When we look further at the racial breakdown of the data, the decrease in life expectancy between 2019 and 2020 was greatest for Hispanic males, whose life expectancy declined by 3.7 years, followed by non-Hispanic Black males with a decline of 3.33 years, non-Hispanic Black females with a decline of 2.4 years, Hispanic females with a decline of 2 years, non-Hispanic white males with a decline of 1.3 years, and non-Hispanic white females with a decline of 1.1 years. The decline of 1.5 years of life expectancy between 2019 and 2020 was primarily due to decrease in mortality due to COVID-19. The COVID-19 had a 73.8% in this negative contribution, followed by unintentional injuries, homicide, diabetes, chronic liver disease. The decline in life expectancy would have been even greater if it were not for the offsetting effect of what we were seeing with the work we've been doing with the decreasing mortality due to our cancer prevention strategies. And this positive effect was determined to be 45.2%, followed by those with chronic lower work done towards chronic lower respiratory disease, heart disease, suicide, and certain conditions originating in the perinatal period. So in summary, the natural progression of colorectal cancer involves genetic mutations and changes in genetic expressions of cells to lead to abnormal tissue growth. Colorectal cancer is preventable, and detection of polyps and their removal by colonoscopy is key. Updated 2021 guidelines call for earlier screening. COVID-19 has impacted screening and treatment, but it's important to follow the guidelines to prevent colorectal cancer. COVID-19 has led to a dramatic decline in life expectancy from 2019 to 2020. The efforts towards colorectal cancer prevention have led to positive contributions to the death rates. There is evidence of recent decline in screening rates as a result of COVID impacting the decades-long gains. It is paramount that we continue our prevention campaign and bring light to the importance of screening. So my takeaway message and recommendation for you is to find out your individual risk. And if you're average risk, you start your colorectal cancer screening at the age of 45. Address all the modifiable risk factors, including diet, smoking, and alcohol, and reach out to your friends and family and make sure they're getting screened. And remember to consult your PCP for referral to a gastroenterologist and find out what your insurance company covers. Thank you.
Thank you so much for that wonderful presentation, Dr. Sansoni. We do have some questions coming in the chat and also from the Facebook live stream. And I appreciate all of you who are out there paying attention and sending us your questions. I'll just share a few with Dr. Sansoni. Hopefully we'll have time to get through all of them. The first one I'd love to hear, for you to highlight for us, and I know you went through a bunch of different ways that folks can be screened, but can you just highlight for us, are all the screening tests the same, or does it matter which one you get? Should some people get one and some people get another one? Tell us a little bit more about that.
Right. So that's a very important question. And thanks for asking that question. Where it comes to matter of screening, it can be a very individual matter to tackle. And it's best to address this with your healthcare provider. For the most part, what I presented here had to do with the average screening individuals. And in terms of the different modalities that are out there, it's gonna, if you are in good health and if you don't have any cardiovascular issues, in general, your primary care doctor is usually sending you for a colonoscopy. And that, I think, is what is pretty much standard of care at this point. But I did highlight that there are different ways to screen, and there are different circumstances to go for a different avenue. And since I showed you like the virtual colonoscopy, that could be available for someone who has like certain cardiopulmonary problems that would dictate, decrease, not having sedation or going that route. And, but I do have to say these other screening methods, if you do elect to go, let's say, the route of a virtual colonoscopy, then you would need to eventually do a colonoscopy if something is found. But if nothing is found, then you would not necessarily need to go through with a colonoscopy.
Thank you. And a good follow-up question came from someone who's joining us on Facebook. And they said, should you get a colonoscopy if you have, and I'll read exactly what they wrote, the MUTYH gene mutation. So if you have the MUTYH gene mutation, should you get a colonoscopy?
Right. And so I highlighted some of these gene mutations early on in the talk. And what I try to drive home is that colon cancer screening can be very individualized, and you can't take that question outside of getting more information in terms of specific family history. We don't necessarily just respond to just the gene mutation, and it may help us to learn more about the family history. So with that information, find out more details about your family history, and it will make a difference in terms of your first colonoscopy and whether or not polyps are found, the type of polyps that are found, so we don't take necessarily the information like that without getting other information to help us to make decisions. So that's going to take some discussion with either your primary care provider or a gastroenterologist to bring all the information together to try to figure out what your risk really is, and then to determine what type of screening you should have.
That's great. Thank you. You're getting lots and lots of kudos. Folks are saying excellent presentation, very informative. I have a question to follow on to that one, actually. So if you have a situation in your family like this person described, or some other family history that makes you concerned, at what age should you see a gastroenterologist? When should you start talking to someone about when your first screening test needs to be? How early should you be talking to someone about this?
Yeah, and that's a very good question. And again, the discussion should happen very early. Like the data that I presented has shown that colorectal cancer is occurring in younger individuals. I'm sure you all know Chadwick Boseman. He is the actor, and he, I think he died when in his 40s and did not have the opportunity to even get tested. But there's things that we can do to figure out our risks. And that is, you have to be more vigilant if you do have a family history. If you are exhibiting any of the signs and symptoms that I alluded to, don't ignore them. These are all things to consider very early on in the discussion, but we don't typically start these screenings as recommended by the various societies that I presented until you're at the age of 45.
And following on that, there are lots and lots of questions about family history. What kinds of things should raise your red flag that something's going on in your family? So someone on, I think in our chat said her maternal grandmother, her mother, her female cousins, all passed away from colon cancer. And she's wondering about a gene mutation in her family. But I'll extend her question even more and say, let's say your history is not as dramatic as hers. And I feel terrible that you lost so many family members. What things should raise your red flag that something is going on in your family and then you are someone who should see a gastroenterologist earlier?
Right. So if you have a family history of colorectal cancer, especially in a first-degree relative, meaning that if this is your mother or your father or a sibling, then we tend to do that procedure either starting, it would be 10 years earlier than what is recommended, or 10 years earlier than that person who had that colorectal cancer. So let's say your mother or father or a sibling had colon cancer at the age of 40, then that would mean that you should start your screening at the age of 30. And so there are other caveats to this as well, because depending on how many family members, like the person in the question, seems like that person has quite a few family members with colorectal cancer. And so we start to entertain things such as the hereditary syndromes that I alluded to. And we have to bring that into discussion, because then you may fit into the category of having something like Lynch syndrome, which is the HNPCC that I presented. And for having that type of syndrome would dictate that you get your colonoscopy starting even earlier, age of 20, and then you would have a colonoscopy every 1 to 2 years, because we know that particular group of people are having colonoscopy, having colorectal cancer much earlier. And I will add, in general, for the average risk person, colorectal cancer and the growth that I showed you in terms of a polyp and how it transforms into colorectal cancer, it is usually the progression usually takes about 10 years. That's usually, but do we have outperformers who are where polyps grow faster? Definitely, but in general, that's what we're seeing. So that's why there's usually points within that progression of a colon polyp to colon cancer where we can intervene and make a difference as far as prevention is concerned.
Now, you mentioned this in your presentation, the effect of the pandemic. And we've had several people on Facebook and in our chat saying that either they have been putting off their screening or that they're finding it hard to get in for screening. What do you recommend that folks do while we're still in the midst of this pandemic? How should they handle their screening?
Right, and that's a very good question. What's happening with at different healthcare providers, different healthcare facilities and centers, is that we had to make adjustments. And with those adjustments, there were some delays in terms of being able to deliver certain types of care. And, you know, what happened was patients were prioritized, especially during the surge. People who needed more emergent care were taken care of ahead of those who needed their screening done. But do know that things change as I presented, and as some of the data presented, things have been in flux, meaning that since if you called once and your provider or your gastroenterologist says that, you know, they're not available to do the screening right now, that might change in a week. That may change in a couple of weeks or in a few months. But so when I say that, the information isn't necessarily stagnant, and we've had to make changes to delivery of care in response to what's happening in COVID. And I think for the most part, there's been an uptick in doing more screenings now than we were before when the surge was occurring, because we know how to deliver that type of care more safely with doing more testing to determine who has COVID and who doesn't, so that we're not infecting the staff and the people who come into our facilities to get screened.
Perfect. I would add to that too, that if you are high risk, like Dr. Sansoni was just talking about, you have a first degree relative, et cetera, then you want to make sure that you communicate to that health center or doctor's office the urgency of your screening versus, like Dr. Sansoni was mentioned, your usual risk. This is just your asymptomatic screening, right, Dr. Sansoni? You would say people should be more persistent. Well, we continue to have more questions. So someone in our chat asked, she mentioned that her husband passed away of colon cancer at age 55, and she has a question for her daughter. Well, how should she counsel her daughter about her need for screening?
Right, and definitely, so that's a first degree relative for her daughter. So her daughter should get screened earlier and do talk to her healthcare provider. But what I'm going to say to introduce something a little different that I didn't bring out in the discussion is that although we have these different methods of screening, they're for average risk usually. If you are determined to be higher risk, then I would forgo all the other methods and just go straight to the colonoscopy and do that as the first screening and continue to do that depending on your risk. Because now we're talking about high risk individuals. Most of the talk was focused on the average risk individual. But again, with that, there's so many nuances. You'd have to figure that out with your primary care physician and your gastroenterologist.
Yeah. One of our attendees on Zoom has a hand raised. And I know we have folks who are helping us with the tech. I'd love to hear her question or his question or comment, but I don't know how to acknowledge them. Can someone who's helping us get to that person? Let's see. While we do that, while we figure out how to acknowledge you, if you have your hand raised, we're coming. Don't think we've forgotten you. I have another question, and that's about research studies. So are there research studies going on in terms of colon cancer screening, treatment, et cetera? And you mentioned that there's increased mortality for African Americans. Are there studies looking at African Americans and trying to figure out why there is that increased mortality? Can folks participate in clinical trials? Can you talk a little bit about that?
Right, and so a lot of the data that I presented here came out of information that the CDC publishes pretty often on the American Cancer Society. And they have epidemiological studies that are ongoing, and we get a lot of our data through those avenues. But as well, in different institutions, such as my institution, we do have ongoing research that is looking more poignantly at different populations to try to delineate what your risks are based on where you may live or any other confounding factors to delineate other risk factors that might be contributing to the discussion in terms of what your risks are. And I think, you know, you asked a little bit about Blacks and in the, for instance, in the Black community and how it's disproportionately affecting Black Americans. The 20% of Black people or African Americans are more likely to get colorectal cancer, and 40% of us are more likely to die from it. And so when we look at the reasons for this, it's very, very complex. And so the research is definitely needed to tease out more of the risk factors that are there, but they're largely what we're finding due to access, due to disparities in healthcare delivery and in treatment and prevention strategy. So there's more. We definitely have areas where there's deficits, and we have to figure out what, you know, need more information in order to make more of a positive impact.
Thank you for that. I saw Ann Nichols with a hand raised, but now she's gone from my screen. Are you there, Ann?
Her question is in the chat.
Aha. Wait, let me find your question.
From me.
Ah, there we go. The question from Ann is, since there's 6 different organizations recommending screening with different screening recommendations, which one do you recommend for the average risk African-American person or Black person?
And Miss Ann Nichols is trying to get me in trouble, but I won't take the bait. Thank you for your question. You know, I think, you know, what I've shown was that the contribution of all of them really gives us very good information in terms of where to go. When I first laid out the data, I showed that the American College of Gastroenterology in 2003 had made the recommendation for African Americans to first get their colonoscopy starting at 45. And then the American Cancer Society quickly followed suit there later on. And then in 2020 and 2021, 2 other societies have now followed suit. Now, if you look at the recommendations, they're all pretty much in alignment in where that is concerned. So I think we have 4 organizations out there that are saying that we should all start at 45. And I showed you that nice graph that showed the exponential growth in the number of patients who are having colorectal cancer over time. That corresponds to why and dictates as to why we should be screened, and it gives us strong evidence to support when to start. So, you know, I say follow the guidelines is saying, you know, 4 organizations out there are saying at this point, start your screening at 45. If you have a family history or something else that dictates, because that's only average risk. And I know, you know, we African Americans were deemed to have risk factors, and you might even think about starting even earlier. But you know, I'm comfortable with the guideline as it is in terms of starting at 45. And that's what I recommend to all my patients, is to start at 45. When you get to 75, then we start to think about other health concerns, because we have to think about whether or not it makes sense to go through a colonoscopy. If your life expectancy is it changes as you get older. And so we have to bring that into the conversation. So we're definitely not necessarily doing colonoscopies in anyone over the age of 85. But between the ages of 75 and 85, then we start to ask the question of, does it make sense at this point? Mm-hmm. But definitely between the age of 50 and 75, you should be screened if you're average risk and even high risk.
Well, you just answered a question for two people, one in our chat and one on Facebook, who are 85-year-olds who asked questions about colonoscopy. So you didn't know we had that question, but you answered it. I see a hand from Dr. Lister. If you can unmute and go ahead and ask your question. Or type it in the chat. You can do either one. Sharon, did you want to ask that question? While she unmutes, someone asked the question, this is another question about screening modality. What about abdominal or pelvic ultrasound to screen for colon cancer? Someone asked that on I think, Facebook.
Okay. In terms of imaging, there are two different types of radiological imaging that are the FDA approved for screening. One I did not present, which is the contrast imaging, barium that we can do looking at the colon itself, but that's not generally recommended. Usually we're doing that if we do a colonoscopy and we're struggling to get through and we can't get to the end during a colonoscopy and you're completely prepped, then we might consider doing a double balloon X-ray, which basically puts contrast into your colon and does X-ray images to look to see if there's any larger lesions there that we need to worry about. And in general, that gives you, if that comes back negative, then you don't need to necessarily address screening again for another 5 years. The other is the virtual colonoscopy, which is the CT colonography, which looks at the colon with either 2D or 3D images using the CAT scan, and you have to do a prep for that. Where the ultrasound is concerned, it is just not recommended at all in terms of screening for colorectal cancer because it does not image the colon or the rectum very well, depending on how you utilize it. But in generally speaking, in terms of imaging the body from the outside, using ultrasound is not going to be the best imaging modality to do that. So it's generally not recommended as a screening method.
Great, thank you for clarifying that. We only have a few minutes left, so we had a couple of questions about diet. So can you highlight the best part? You mentioned it in the presentation for sure, but since this is something that we can all control, what we eat on a daily basis, can you highlight the best practices regarding diet in terms of reducing the risk for colon cancer? And a corollary to that is someone had asked, what are the right foods that can decrease your risk? I'm not sure if they're right foods, but can you talk a little bit about diet and colon cancer risk?
Right. And so we want to avoid diets that are high in red meat. We've shown a direct correlation between consuming over 100 grams of red meat per day with having a higher incidence of colorectal cancer. We also want to avoid processed meats because we've also shown in studies having more than 50 grams of dietary intake of processed meats daily is associated with a higher incidence of colorectal cancer. Cole, I like to
50 grams in sandwiches. How many sandwiches? What's that in Subway sandwiches?
Well, I like to look at this a little differently because when we are taking care of our health, we want to think of our health in a whole. because there's definitely, when you're taking care of your colon, you're taking care of the other organs in your body. And they're a lot happier if you consume a diet rich in vegetables, fruits, whole grains, the stuff that we've been talking about for a long time now. All of that is definitely information that we should be utilizing to just take care of our general health. And all of this, a diet with those that being your source of nutrition has been shown to have a positive effect in preventing colorectal polyps and colorectal cancer.
So I think ultimately it comes down to do what your mother told you.
Yes. or your doctor told you.
How many things in life come back to that? Eat your veggies, get your exercise. I don't see any more questions, but I just want to say a final thank you so much to all of you who've attended. I hope you have gotten a lot out of this presentation. And Dr. Sansoni, can you bring up your slides? Do you have your last slide where you had the takeaways? Can we put that back on the screen for everyone as we close? If it's easy, you can just share that again. If not, that's okay. Important things are you definitely want to get screened. You definitely want to know your family history so that you can start talking to your doctor about what is the right age for you to get screened. In the absence of any other information or symptoms, age 45, we should start getting screening and eat a healthy diet, high in vegetables, low in processed foods, because that's going to be healthier for you. I hope you got some other takeaways from this presentation today. Please, the Facebook Live is going to be up if you joined us through that link. So definitely you can share that with family and friends. We so appreciate you for being here today. Share this information with one more person. You can save a life. I think Jessica needs to take over again so she can give us some information. And I thank you for your attention today. Thank you so much, Dr. Sansoni. Thank you, Dr. Halyard, and our friends at Mayo for hosting us today.
Thank you, Dr. Thompson and Dr. Sansoni. As you mentioned, we will be making this recording available through Facebook Live/Mayo Clinic. So be looking for that. I think Jessica is going to make some additional comments. Jessica? Or perhaps that was it. Well, thanks for joining us today. And again, please share this information with everybody that you know. It is so vital. Thank you so very much, and we'll say goodbye today.
Thanks for coming, everybody.
Thank you.